Thank you very much for the very warm welcome to come and talk to you today. I'm going to do hopefully about 25 to 30 minutes, just talking a little around a concept that we've been working with for about 10 years now in terms of thinking about its relevance and how to shape what we do in correctional services around people who display harm to self and others. So I'm going to try and move on the slides, but it's... Oh, there we go. Okay. So as I've said, the definition around dual harm that we're going to be using today is really thinking about something that we kind of talk about in clinical practice quite a lot, which is around people who are displaying harm to self and others. It often turns into something that we talk about quite a lot in shorthand. And in this, I'm talking around people who were violent and also harm themselves, so self-harm and suicidal behaviours. And part of the challenge and why dual harm is a real area that we've started to think about is about the separation between how we conceptualise violence and self-harm, how our research, how our theories, how our practice have separated those two behaviours out. And so often our policies that follow from our research and theory really think about these behaviours separately. Our services often separate them out, particularly in correctional settings where violence is often the jurisdiction of our correctional services, criminal justice sector, whereas self-harm moves more towards a health lens and a health services. And that separation works to a point, but also means that actually what we don't have is a really good understanding of where that co-occurrence happens and who those people are and what their needs are. So we know, for instance, and I'm going to shorthand, that there's a very strong relationship between these two behaviours. This has been known for a long time. And in the general population, around 50% of people who self-harm will at some point engage in aggression as well. And around a quarter to a third of people who engage in violence in the community will at some point also self-harm. So the overlap between these behaviours at an individual level is pretty high. There's a pretty good chance that if you're working with one behaviour, the other behaviour is somewhere either in the history or in the future. So we know they often co-occur, but why is this? What is it that means that some people will engage in two rather than just the one behaviour in their lifetime? So I'm going to take you back before we think about some of the correctional work, is where does it begin? Why is it that some people move towards a behavioural profile that encapsulates both violence and self-harm? And I'm just going to summarise some of the research that's been going on, particularly in the last few years, which is trying to capture the unique factors and background of these individuals. And although the risk factors and the experiences of people who are violent and self-harm can often overlap, there are, clearly similarities sometimes in those behaviours, in those experiences. What the research is showing is that for people who develop both behaviours, it's often characterised by either extreme violence in the home or by carers. And that's comparatively either more extreme or more chronic. It follows throughout their childhood or for a number of years. And that exposure to that chronic and or extreme violence is kind of setting the groundwork, the framework, the underpinnings. But interestingly, they also talk about within that they have a lack of safe spaces. So it's not just about the violence in the home, it's what else is around. That the people around those individuals are also not particularly safe, or they have a safe space, at one point in their life. It can be a teacher, it can be a grandparent, it can be another person. And that is lost at some point in that experience. And so they've got this real strong wish for connection. They've had connection and then they lose it. And that loss, and it can be a parent as well, the research is showing that what we're seeing is this kind of combination of wanting connection, but also of extreme behaviours in their early life. So the behaviours develop to manage the emotional, the relational, the trauma in their lives when they're relatively young, throughout their childhood and adolescence. And these behaviours are adaptive to meet the environmental needs, the scenarios with which they're needing to resolve how it feels, but also to protect themselves. And often also they're talking about protecting others. And that can be a sibling, that can be a parent, it can be a partner. And these behaviours are all part of trying to manage that experience. But they also start talking about how they develop a kind of duality of identity. There's a kind of public face and then a private face that they are developing. And I'm not saying that they've got two completely separate identities. I'm saying that they're putting on different faces at different points. And it kind of helps us to understand how you get multiple behaviours, because it depends on the circumstances and the identity that needs to be in play. They also report around wanting to seek out connection. And this, I think, is important. Sometimes we can see people who are violent as people who don't care, or people who have some of these trauma as withdrawing. Generally speaking, people who do harm are talking about wanting connection. And the behaviours that they developed young actually being part of how that supports connection. And that could be through connection with gangs, in the violence. It can be connection with peers who self-harm. And actually, it's all part of that. And they also express how they develop deep emotional experiences. So we're not seeing necessarily the alexithymia theme, for instance, doesn't seem to distinguish this group. It's deep anger and sadness very much can typify their experiences, but also a really strong sense of loyalty, back to that idea of connection. And that can be towards different groups of people. Now, this is not going to become us a surprise, but we are now aware of some of the outcomes of some of that early experience on people who dual harm. We are seeing far higher levels of being expelled from school, and they're also developing higher levels of post-traumatic stress disorder, early substance dependence, personality disorder coming through later in life. Although, interestingly, far lower levels of depressive disorders than other groups, such as people who self-harm without violence. But interestingly, in addition to not being at school and having that supportive possibility in their lives, they also were experiencing far less access to mental health services throughout their early lives. And this is kind of leading on, really, to where correctional services start coming into play. We now know that they're 5 times more likely to be convicted of a violent offence if you've required medical treatment for self-harm when you are young. And we are seeing within the dual harm population, particularly those in prison, far, far earlier contact with the criminal justice system. And we are talking pre-teens quite often sort of level. So where they are is not in school, they're not in our health services, but they are in contact with our criminal justice system. So in terms of why dual harm then occurs when people are in prison, which is what we're coming on to, we start to see that early experiences playing out. They're re-experiencing difficult and unpredictable environments, often violent environments, and they need to adapt to these scenarios. We're seeing dual harm being used for emotional and psychological management very strongly around the protection of themselves, but also others. 2 types of identities, the public and private self, being used for communication and also they talk very strongly about the connections between current scenarios and those early adverse experiences, and the sometimes re-emergence of some of those behaviours in prison, which actually they haven't used for some time, since maybe those early years. But we're not seeing, this is not a homogenous group by any means, and I don't need to give that idea. There's no single function. The environment, the identities, the people, their personalities, and those social interactions are driving the different behaviours in different ways. So I'm just going to touch upon some of the work that we've been doing in prisons. So this very much focuses on correctional dual harm and some of the risks. And so for this, we've had to use sort of existing data. And what we've used is where physical assault has taken place. So there has been connection, not the broader definition of aggression, but there's been a physical assault, but also that self-harm is irrespective of the intent of suicidality. Data doesn't distinguish that. And what that is showing is that of people in a prison, this was everybody who was in a prison, it's about 1,000 people, around half of people don't have any incidents on their record at all. About 9% have incidences that are not harmful, so don't fit into the physical assault or self-harm. We have 7% who solely self-harm, 23% who were violent without self-harm, and about 11% who had dual harmed whilst inside prison. And this is over a 5-year approximate timeline. In some other prisons, though, that number is sometimes higher. We get to about 16% in long-stay prisons. So the prevalence of dual harm, people who will do both behaviours in prison, is relatively large, especially when you start to think about sole self-harm being relatively small. And the reason for that, as why self-harm is quite small, is the overlap between the behaviours. So of people who are violent in prison, around a quarter to a third will self-harm whilst they're also in prison. Of people who self-harm in prison, and that includes suicidal behaviours, as I mentioned, about 2/3, and it can come up to about 3/4 in some populations, will be violent whilst they're in prison. So we start to see that the overlap between these behaviours in corrections is very large. We are talking about a very likelihood that both behaviours will start to emerge or re-emerge for some people. The same sort of story is in women as well. We've only got one study so far that's been published around women and dual harm, but it's seeing similar-ish figures where about a third of people who were violent in prison will self-harm, and about 40% of people who self-harm will be violent in prison. This is slightly affected by the rate of self-harm in women in our prisons is extremely high in compared to men, and so it's obviously morphing a little bit of the overlap. So in addition to proving, I suppose, to you that there's something here about how are we working with both behaviours, is thinking about some of the other impacts. What we are finding, and we've done a number of studies now in the US as well as in the UK, that dual harm, people who dual harm whilst in prison, not only have both of those behaviours, they're also having a disproportionate impact on other kinds of misconduct within the prison. And what this is showing is of the 11% of people who dual harm, and in this picture it's in the purple, account for 56% of reported prison incidences, not including self-harm and violent behaviour. So they are disproportionately having an impact on the stability of prisons, and therefore we really do need to get a grip of what is going on for these individuals and how can we work with them better. Now, one of the questions that one of my early questions on this was, well, what is it that's driving that higher rate? Is it that these are individuals who are at the extreme ends of self-harm and assault, the people who are the really high flyers in our prison system? Well, the answer to that, and take away this message, is no, they aren't. And what we've shown now in all of the studies that we've done 6 so far, is that the rate of self-harm and assault by people who dual harm is almost exactly the same as people who do one behaviour but not both. So yes, they're double counting because they're doing both, but they're not more. They're not more serious. They're not more frequent, and they're not more likely to assault staff. So they're very similar in terms of the rate. Where the big story of why they're contributing is actually in 2 other types of behaviours. And one of those is property damage. So it might be smashing the cell up or other kinds of damage, or disorder, which is essentially about not following the rules or disrupting the regime. And so you can start to see how you get this more expressive behaviour being part of their patterns. And I like to think of it as they're very adaptable. They're responding to their environment. They're adjusting to it. You're seeing these expressive behaviours come in different ways, possibly because of the different scenarios that they're experiencing. But we're not seeing this coming through with drug-related incidences or drug supply, mobile phones in prisons, which are illegal. So we don't think they're driving a story around substance use or organised crime, as we see with people who are violent without self-harm. They really are a mix between people who will self-harm and be violent. Now, one of the big management challenges, sort of leading back to the question of separation, is if somebody's violent in prison or in the community, what generally happens is we move down a kind of zero tolerance approach to violence. We see violence as something that needs controlling, punishing, and stopping in a way that often becomes quite controlling. Self-harm often takes us down a different path. And that takes us down often to healthcare, but think about people who self-harm as more vulnerable, supportive care. And these 2 realities don't really coexist very well together if you're thinking about somebody who has both behaviours. How do we work with somebody who needs both, who is being both violent and self-harming? How do we view them? Now, one of the big challenges that we have, particularly around responding to violence, is the options that are available. And I'm going to talk to you about one of those outcomes. If somebody's violent in prison, particularly to a staff member, segregation or solitary confinement, there are lots of different phrases for it around the world, but essentially where somebody's removed from their normal location to an isolated one, is often what will occur. And it can be for punishment, it can be protection from themselves or from others. It can be for suicide risk. People are often moved to isolated location for suicide risk. But importantly, for what's called the good order of the prison. If somebody's disruptive, as people who dual harm may well be, they may be moved for the good order. But one of the challenges of this isolation is it often also results in limited interaction, family contact, privacy. They won't access purposeful activity in the same way, or their usual coping strategies that they might use in their normal location. Now, we know that segregation is not particularly effective in any kind of long-term way. It doesn't reduce prison misconduct. It doesn't affect recidivism. We know that over 15 days, much more likely to cause a more profound physical, psychological harm. And it also can increase the risk of self-harm occurring while somebody is on restriction. And so what we wanted to look at was, are people who dual harm being disproportionately affected? And what we were looking at, and I'm sorry, the bottom of this slide doesn't quite, the things have gone out, but at the time that people were spending there. Now, before actually I talk that through, our system, as do a number of systems, say that we shouldn't be putting people in segregation if they're at risk of suicide or self-harm. It's an exceptional circumstance only that should happen because it recognises the vulnerability of that cohort. And what this was showing, and this graph shows, is on the left-hand side is the number of days that people who had no harm incidents on their record, 5 days. The one next to it is people who solely self-harmed without violence, about 7 days over the course of about a 5-year period, I would say. The blue one are people who are violent and don't self-harm. So on average, they were spending 19 days. And then the big column are people who had dual harmed whilst in prison. And they were spending on average 51 days in segregation. And that's 2.5 times longer than people who were violent without self-harm. So it was throwing on its head a little bit about this idea that people shouldn't be put in segregation if they're at risk of self-harm. We also looked at another form of restriction. We have one in the UK where people are restricted within their own cell. And this also showed that people would spend 2.5 times longer if they had dual harmed than other groups. And what this worked out as was an average of 9 months would be spent on restriction in a 5-year period. So it's about 1 in every 6 days. And so they weren't accessing the usual coping, visiting activities out of their peers. So we looked as well at education as a marker of this. And what this showed, because education is very useful for preventing violence in prison, but also reoffending, is people who, as they came into prison, people who dual harmed have a lower reading score on entry than other groups that we were looking at. Now, this isn't a surprise necessarily, given what we know about their early life and education experience. But what was interesting was that during their stay, every other group improved their reading score on average. A reasonable proportion. People who dual harm did not. And the interpretation of that is that actually they were not receiving education, they were not receiving it consistently, and actually the restrictions that they were experiencing affects actually other factors that might support the prevention of violence, as well as other outcomes. So in terms of thinking about their risk to themselves in terms of outcomes, we are starting to see some concerning outcomes around mortality as well. We showed relatively early on that people who self-harm between people who dual harm and self-harm without violence, people who dual harm are far more likely to use ligatures and overdose as a way of self-harming, which I'm sure you'll recognise is going to more likely lead to a lethal outcome than some of the other options and methods that are used. And this increases their risk. And we're starting to see that play out now. And this is a study that is looking at mortality after people have been in the community. So they've been released. And what this was showing was that out of, there's about 470 deaths that this captures. Now, in that, this is about violence conviction and where the risk of suicide and self-harm was identified. So it's a slightly different definition, just the data, unfortunately, is different. But what we were seeing was that of people who met that definition of dual harm was made up about 38% of our sample. But they are disproportionately overrepresented in deaths by both drug poisoning and suicide. So we are seeing their increased risk playing out throughout a much longer period of time. So although people who self-harm without violence are also at higher prevalence in suicide, we're not seeing that playing out with drug poisoning. And we're also not seeing that in violence either. A little sort of fact that I quite like I quite like these sorts of simple percentages. But of people who, so out of people who died by suicide in this sample, 90% of them either had a suicide and self-harm risk or a current violent conviction. So if you put them together, those three groups of violence and self-harm, along with the dual harm, you can make up 90% of suicides and 92% of drug poisonings just from those two factors alone. So they are, violence is a really important feature often of people who die on probation. So to sort of finish up is just thinking about, well, what can we do about it? We have this separation in what we do. We have the separation in our research, the theories that we use, the practice that we often utilise in corrections. And there's a few practical steps that I like to suggest. The first of which is knowing who they are. A lot of our systems don't easily capture knowing that somebody has two vulnerabilities, which capture both violence and the risk of self-harm or suicide. They capture one but not the other. And actually just knowing who they are can help us to think about how can we combine the decision making and the case management of these individuals to take account of these dual risks and needs. How can we think about our assessments so that we are bringing together assessments, our formulations around these behaviours rather than operating them independently? How can we think about our use of restriction to safeguard it in a way that recognises the vulnerabilities of particular groups, particularly these people who might self-harm, and their overuse? How can we improve the quality of our access to positive environment? So how can we maintain that positive environment with people who maybe are disruptive in our prisons? What can that look like? What can we keep? And what can we not? And then also within that, monitor and responding to these disproportionate outcomes. We did not know that segregation was an issue for this particular group until we looked at it. So how can we continue to monitor and respond? And then finally, it's about maximising each of the touch points. These individuals have touch points throughout their lives with lots of different services and people, if only through the criminal justice. How can we maximise those to try and identify and move people away? So to finish up, my conclusion then is I want you to be clear, I suppose, that although people who do harm are disruptive in prisons, they're not more dangerous, and we shouldn't be treating them as such. What they have is a cycle of compounded negative outcomes throughout childhood and into imprisonment, which means that we really need to think about how can we better address the root causes of those behaviours. And we have some ideas around what that needs to look like, around emotional well-being, connection, feeling safe, access to activities. But also thinking about what prevention looks like. So we're not just reacting to the behaviours after they happen. And also to be curious and brave around thinking, actually, how well do our existing practices and assumptions respond to dual harm as a concept? Does it recognise and can it respond well? So thank you very much. That was the end of my talk. Okay. And I'm going to try and come back out.
Perfect. Thank you so much, Karen. That was fascinating. And I must admit, that's an area that I have not encountered very much at all. So I learned a lot and I have a lot of questions. And I'm sure a lot of other folks have a lot of questions. And I just want to commend you as well for the amazing work that you've been leading and supporting within the UK on this topic. Like many topics in justice health, likely under research. So congratulations.
Yeah, it's not just a space. Yeah.
I just want to encourage folks who are attending, if comfortable, just for the discussion. It's always nice to see your faces. You can pop questions in the chat or you can put your hand up and we can go through them. I might sneak in a cheeky question while others are collecting their own thoughts. I'm just thinking back to I think the second to last slide or the third to last slide around what do we do about this. The first box you had was know who they are. And I'm just wondering, in the studies that you've done, have you looked at the characteristics of those who are displaying dual harm? And I guess what was coming to my mind was overlap, if there was an overlap and co-occurrence of other mental health issues or neurodevelopmental disability or traumatic brain injury, for example, and just looking at the types of behaviors that were more common among this group being the property damage disorder. And I wondered if there was a relation with, potentially distress or behavioral dysregulation that was also mixed in there. If there was, I mean, I'm probably getting ahead of myself, but to the original question of like who are the people in the cohorts that you're
Mhm.
working with that are displaying to
Yeah.
effect? Are there any differences that you've noticed?
Um, the simple answer is, and I think it's the answer for most things, isn't it? If going, we actually know very little. We know a lot less than I think we probably should do. And at the moment, I don't think there's an awful lot known around mental health, neurodevelopmental areas in any sense in this population. I think it's a real area that we really need to dig more into. There is some work that's been done in forensic mental health, a little bit, but it hasn't really looked at that question yet. What that was showing was that you do start to see, when you're working with much more forensic mental health population, you get slightly different stories than people in prison who do harm, and the mental health, the role of mental health comes through much more strongly, as you might imagine, in their behaviours. But yeah, so the simple answer is I don't know yet, and we've only just started to look at that. I think
Mm-hmm.
as a field.
And I guess, and I'll just keep going. And again, put your hands up if you have questions. My thinking then goes to like, how do we find out more about that? And you know,
Mm,
if you had a magic wand, or maybe you already do, and you've got some ideas and what's feasible, at least in the UK, around what information will we need, what data would we need to bring together to understand more about this
mhm.
population and their characteristics, whether that's corrections data or using that with linked data or some other forms of information.
I think there's lots of different ways in which it could be developed. I think whereby I think a health specific data where it would need to be linked in some way to justice data in terms of even on the terms of violence convictions, which is generally how the other parts of the field are using it at the moment, is linking it to that, and that's not an easy thing to do. So anywhere, I mean, there's very few spaces that we can do that at the moment. In the justice side, which is generally where I sit, hence why that's where I know my data. We are we do have a system where the prison staff can now access information around where somebody has been identified as a suicide or self-harm risk, and has violent behaviour or violent offending in their history. So they can actually see who those individuals are. And as data is received through whatever channels that is in terms of risk, it can be updated accordingly so that it's alive and it's a live dashboard system,
Mhm.
which means that when somebody's dealing with one behaviour, it allows them to be able to, at least with one set of data, to identify who they are and therefore think about it in their decision making, in terms of working with that. I think the real challenge is the linking of health and justice data. And if there's one group that understands that better than anybody, it's this one.
And coming from the UK, like there's an impressive system for linking data in the UK. You know, it's even a challenge there, so completely
Mhm.
similarly in Australia. But I think what I hear from that as well is it's not just about what we're doing on the research end, but this intersection of working with folks in corrections and correctional authorities and the people on the ground to really
Mm.
understand the complex issue and how to respond to it as well.
Yeah.
Um, I might just throw over to Allison because she's had her hand up. So over to you, Allison. Looks like she might be
Oh, it
frozen.
looks like she might be frozen. Yeah.
All right, maybe. Oh, there she is.
Oh no, this is.
I'm not sure if I can't hear Allison. Can anyone else? Okay, maybe we'll move on to
Okay.
Cameron. Allison, if you want to put your chat in or your question in the chat, we can do it that way too. Over to you, Cameron.
Oh, thanks, Karen. Yeah, that very interesting presentation. I was just interested in whether there's been any studies where there's been application of the healthcare and connection side of things to people with dual harm, and whether that had any effect on the violence side of things?
As far as I'm aware at the moment, I'm not aware of anything that has specifically, I suppose, set up interventions in order to do that. The only thing I can think of is one from a very long time ago at Rampton Hospital that was looking at a particular group, I suppose, with personality disorder, and in their personality disorder unit that looked at some work, but it was a very small N, and I wouldn't. I mean, I'm quite happy to share that paper just out of interest, but it's almost a very unique group of individuals. But I'm not aware of much else that has specifically looked at how it addresses this group's.
Okay. Yeah, I mean, to me, it would be a very interesting thing because a lot of the punishment would be motivated by fear, whereas treatment may have great results.
Yeah.
Just a comment.
Yeah, and I absolutely agree. I mean, there's probably quite a lot of things that we already do that could help to work with this group. It's not that I'm necessarily, not advocating that we need something completely new. I mean, maybe we do, but we don't know yet. But even reporting, and I suppose as researchers, as practitioners, it's useful to think about actually reporting the profile and the outcomes of interventions on both behaviours, because the scale of the overlap is so large that it would, I think, even that would give us indications of potential approaches. At the moment, we haven't got it, or at least not much of it.
Yeah, thanks very much, Karen.
I'll just read. So Alison's put her question in the chat. She says, not sure what happened there. Fascinating work. She's wondering, given the strong attachment and regulation issues, are there prisons in which provide support in these areas in the form of mentoring or buddying at entry or prior to release?
I mean, I wouldn't say that I know of them specifically for this, for this particular group. I mean, there are, a number of examples of that in other ways, but I'm not aware whether there's been any specific look at it. And I suppose it's a bit like I was saying to Cameron. It's actually, if we could report more of just what we're already doing, and whether it might be something that's useful for this group, would be really helpful to know. So. Sometimes small things like reporting on outcomes and the groups that we've got and how well they're working would be incredibly valuable right now. I'm afraid my answer to most questions is we don't know, I'm afraid. So
classic response in public health, or it depends, is a big one as well.
Yeah.
Given that no one's got their hand up, I'm going to sneak in another question. And mine was also just thinking back to like the so what, or what do we do about this? And I know a lot of it depends on generating more information, which it sounds like you're doing. And I'm just thinking, based on what you know, what do you think are some of the best solutions? And I guess the second part of that question is, do you have any plans to be, or are you working with any correctional authorities or specific sites in the UK to work on this kind of at the ground level and just not translate some knowledge and see what they have to say about that and what could be done?
Yes, I think there are pockets, I think, of specific. I think now that there's sort of awareness, I suppose, of the overlap, because I feel like that's my main message all the time now, is going, let's do things more knowledgeably and focused on thinking about how might this work or not work for this group, and are they becoming do they need something different, or do they need something that's just a bit more mindful of the fact that they have there's a number of different outcomes that might come from what we're already doing. And I'm aware of a couple of sites that have been using acceptance commitment therapy, compassion focused therapy with people who do harm. And the compassion focus haven't reported back to me yet, but the ACT is saying that they're finding that quite a helpful intervention. Again, it's not published and it's a very small end. It's very much we're seeing how people are finding this as a method. I'm seeing quite a lot now of combining assessments. So where somebody, particularly in corrections, where they might be referred for violent assessment, they're actually thinking around self-harm and suicidality alongside it. But so that when thinking around how to develop a plan of how to manage the violence alongside the risk of self-harm. So it is changing some of the plans about response to these individuals, which is a bit of a long-term plan to see how that works. There is definitely work as well. The guidance in the UK has changed, and it's a slow. Changes are slow, but the guidance has changed and the processes will eventually change behind it, but of actually combining the case manager. So where you've got violence and self-harm in the same individual and you're managing that they'll have the same case manager managing both rather than having two separate individuals. And that way then you are bringing a multidisciplinary team around an individual to try and make sure that you're not making one worse while trying to solve the other, which is generally how things have potentially been viewed. So I think it's the early thing. There's pockets. I've also actually some of the formulation stuff in our personality disorder pathway. I understand they're combining. They're thinking about pulling formulations together in terms of thinking about treatment options and what that needs to look like at an individual level. So in some respects, it's not too tricky to do some things where you are doing it more mindfully rather than accidentally. And I think probably that's where we are right now.
Yeah, it sounds like just education would be an important component of that for those interacting with this population. There's a few questions in the chat from Trixie. I'll just read them out. So the first one is, what advice do you have for staff working in systems where the good order and safety of the prison will come before access to connections and purposeful use of time, namely in relation to the individuals engaging in dual harm and are being segregated? Great question.
I think probably, I was going to say, what do I normally say to this question in reality to people is, if you want good order and safety in your prison, by addressing this particular group really effectively and well, you can bring greater stability relatively quickly, I suppose, in the sense of I'm not saying in the next day or two, but certainly in the medium term, it can actually help the longer term good order and safety of the prison. Because and doing individualized assessments of risk rather than blanket policies is where I would very strongly move to try and suggest to systems that's where they need to move to. There's quite a lot of systems that I've worked with who are very reactive. It's almost like they start at the extreme end of going and then they have to be negotiated down, and actually thinking about what is the minimum level of safety that's required as your immediate response, and then build on top of that rather than the other way around. And thinking about pre-planning individual response plans. So we've been doing some of that in our juvenile estate around pre-planning response to violence, so that can be done in a calmer way and including the young person in that, so that across the system we have a shared understanding of what good response looks like at an individual level rather than blanket policy decisions. often having to be made in quick time by people who, there is no way you can educate your way out of everybody, out the system. So if someone's got a plan in advance, they're much more likely to follow it. So some of those changes to a perception of what the purpose is, I suppose, of it, and the medium, not just even long-term responses. But it does take some resource, and it does take some time to do that, I'm afraid.
Thanks so much, Karen, for such a balanced and thoughtful response. There's another question from Trixie, and then we've got one from Shalina. So I'll just do that. Trixie's second question. You cited the education or the USA study on structured, purposeful education activities and paid work on preventing violence in custody. Are you aware of any research on outcomes on reducing recidivism on release?
Yeah, as in of being able to go to education and recidivism. Is that the?
Yeah, just any, I guess, structured activities.
Yes, I do. I can't name them off the top of my head, but I do have them, yes, somewhere in my list. So I can send them around. I can find them and let you have them. But yes, there's quite a lot around the relevance of purposeful activities, work and education in prison, and its beneficial effect on recidivism. Now it's a growing body, which is why I think for me it's a really important. There's lots of reasons why going to do these things are very good from a recidivism well-being as well as social perspective. So, but yeah, I'm not going to even attempt to try and remember what they're called off the top of my head, I'm afraid.
If it's okay with you, Karen, do you mind if we put your email in the chat, and then anyone
who's
got any questions, they can email you?
Absolutely, yes.
Okay, so we'll just move on to Shalina's question in the chat. So other than, sorry, not in the chat, it's just to me. So others, if you can't see it, that's fine. Other than linked data analysis, are you able to comment on the adequacy of initial assessments on entry to custody to identify these dual client, not just in terms of risk, but also therapeutic needs and nature of in-person service responses, programs, and activities, thus beyond simple placement decisions, but for case management and through care planning? These are great questions.
That's a big question. I think I'm going to say I've yet to find one that I would say is the gold standard on that question. I think I worked in prisons for 15 years before sort of working alongside them, and I'm very well aware of the challenges as people come into prison of time, resources, and how people are feeling at that point. The best systems that I've seen, I suppose, are ones where there's an screening where it's on first entry, and that you get the right people and the right trained people to do those initial screens and conversations with people in a way that allows some ability to talk, not just ask questions and short answer questions, and that there's then a secondary set of screens and conversations and assessments that are done, usually within 72 hours of arrival by different professional groups. And by doing a more stepped approach and longer term inductions, that's the other thing that I've seen that varies considerably around. I've seen some that go up to a week as people first come in, where they get a huge amount of input and opportunity to discuss what they need, and for those things to be put in place before final placement decisions are made. All of those things, and certainly the ones that work that go to the top end of that, seem to be much, much more effective in identifying people's needs and getting them to the right places at the right time, to the right people that need to support that. That's a little, is my utopia dust that I'm sort of throwing around a little bit there. But I don't think our current systems would be very good at identifying people as needs. I mean, it might identify some risks, but I'm not going to suggest that most of them don't really identify needs and are nimble enough to connect people to them currently. But very variable on that question.
Thanks, Karen. We've just got a few questions or a few minutes left, and I'm just wanting to, just given that there's no other questions at the moment, just really, really quickly, I just want to make sure we're not forgetting about young people in youth detention settings, and just really curious in 30 seconds what you know about this dual harm in youth populations. Is that something that you're thinking about?
Yeah, we've I mean, the youngest of the studies that we've done so far have gone from 18, so that's as young as we've gone. But we have done some work around. It was particularly focused around violence in our young, so in our under 18 facilities, because violence was very much because it was young men. Because we have very, very few girls in our system now, but in the UK. But so we're very much focused on violence, but remapping what we were doing around our response to violence with these young men to really think about the possible risk of self-harm, both now and in the future for this cohort. So although violence was very much the front and centre in your face behaviour in that cohort, it is so it can get a little lost in the story, but actually just by remapping some of their processes and thinking, so that it's always part of the narrative, it's always part of thinking about young men and young people as having, there's a reason that very young people end up in detention, which is often the story that we've been hearing about today. These are not people who've had often good lives, and that. Yeah, I don't think there's a simple answer to that, other than I think we have a lot left to do around understanding.
Yeah, well, clearly no simple answers, and you've done an incredible job and these amazing questions. So thank you so much, and everyone, please join me for thanking Karen for joining us today and taking some time out of her day.